Yeah, we are live now.
Yes. So, very good evening, one and all. I take the immense pleasure to invite you to the OGSSI Journal Club along with Foxy. And this gives us immense pleasure to invite our new president, Dr. Jaideep Tang, sir, and our secretary who will be joining shortly, Dr. Madhuri, madam, and our clinical research committee chairperson, Dr. Sureka, madam, and the vice president, South Zone, the ever-loving vice president, Dr. Charmila, madam, is there. So we'll go ahead and start with the journal club. Can I have the next slide, please? Okay, I take immense pleasure to invite my co-chair, Dr. Mona Pramila, and she will be the master of ceremony for today's session. Can we have the next one, please? Okay, so I would like to invite everyone for the Tamil Thai Valto.
Can I
Can we
just
all
ask
raise?
the technical person to give the number and password?
Yeah,
Madhuri ma'am is not
Savitri?
able to join, please.
I will share in chat box now.
Okay. Yeah, can you just do the meeting like password and the ID? Put it in the chat box so that others can join as well. So I would request everybody to raise. So thank you. I would like to invite all the dignitaries and the delegates for the lighting of the Kuttuvilakku. Can we have the video, please? So usually we try to give a light of knowledge and take away the darkness of and more knowledge about Journal Club. We have been doing it for the past 1 year, and we'll be looking forward to go further. Okay, I would like to invite Dr. Kundavi Shankar, Madam, our Honorable Secretary for this year 2023. Madam is a diplomat in reproductive medicine, and everybody in fertility field will know Kundavi, Madam. She has been a fertility specialist in the IRM.
Priya, what's the password? Madhuri Madam is asking for the password.
I'll share password, ma'am. A webinar ID
share the link.
posted in
Link,
ma'am.
Yeah.
Ma'am,
it's not opening. It's not opening, Madam is telling.
The meeting ID is 859
1 minute.
9276. Shahidi, can you give the password?
Tell me 859.
859 31 318 99 276, madam. No password for the faculty link, madam. Once you put the meeting ID, it just opens. Should I repeat it, madam?
Yeah, 859 318 99 276.
Yes, madam. Absolutely.
Okay. Right, you keep going. Sorry, Priya.
Yes.
Madam joined.
Thank you.
Madam joined.
You can see in your WhatsApp message also, madam. I have already.
Yeah. Madam joined. Yeah.
Okay.
Madam,
okay.
Madhuri Patel, madam, is joined. Welcome, madam. Welcome. Let me introduce Dr. Kundavi Shankar, madam. She's a consultant in the reproductive medicine in IRM MMM, and she's been member of the OGSSI, IMA, TAPISAR, ISAR. Over to you, madam, for the OGSSI prayer. So can we go to the next slide?
Thank you, God, in humility together. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Magnanimity of your endless love. Yes, ma'am. Thank you. Thank you. Kind of you, madam. Can we have the next slide? So it is my pleasure to introduce our most dynamic president, Dr. Jairani Kamaraj. Madam is a consultant reproductive medicine in Akash Fertility Center, Vadaparni. She's been the president OGSSI, treasurer of TAPISAR, and many more laurels. She's been member in more of the society. And the medals, if we read, there will be a lot of time we'll be taking.
thank
So
you.
over to you, madam, for the president address and to welcome the chief guest.
Thank you, Priya.
Next slide, please.
Good evening, and respected our Foxy President, Dr. Jaideep Thanks, sir. Respected Madam Secretary General, Dr. Madhuri Patel, Madam. Dear and loving Charmla Ayavu, our South Zone President, Vice President. And my dear Surekha, it has been a great pleasure and honor to welcome you all for this Clinical Research Committee of OGSSI, along with Foxy Journal Club, which we are conducting over the past 1 year, every second Tuesday. It is a very, very, knowledge-packed and a well-shared, and all the youngsters are very much appreciating this journal club, which we have been doing regularly every month. And today, in this, we have our Secretary General and the President, sir, for this journal club. And I'm very happy on behalf of OGSSI. I welcome you, sir and madam. And today we have a very many new cases. Every month they discuss a lot of cases, which was very useful for the postgraduates. And today we have the senior faculty, Dr. Shyam Pyari Jaiswal from Lucknow and Dr. Geeta from ACS Medical College to be the moderators. And Dr. Nandita Thakkar, a senior fertility specialist, will be the expert. And they will be discussing on interesting cases. And this journal club has been throwing a lot of insights about how to present. Right from the beginning, we had taken a lot of work on the clinical research, how they have to present the paper, how they have to write the paper. Everything has been given in detail for the postgraduates. And every month they were discussing a lot of cases, which has been very well appreciated by all over the nation. So my very special thanks and appreciations and gratitude to my OGSSI Clinical Research Committee headed by Priya Kannappan and Mohana Pramila, who were the persons behind this work of all this Foxy. And very special thanks to Priya. And I welcome all the senior faculties and also all the postgraduates who are joined here for this webinar. And I'm very grateful for Dr. Surekha, who has been a dynamic support for our team to make this program a very informative and very knowledgeable one. And a very special welcome to our Vice President South Zone, Dr. Charmla, who has a great, she was very much into the clinical research and she has done a lot of work in this committee. And it is very apt to have you, Charmla, here with us. We welcome you all. And over to Mohana Pramila. Can we have the inauguration? Yes, sir is there. I have the great pleasure to welcome our president, Dr. Jaideep Thanks, sir, who is the president Foxy. And sir, don't need any introduction. He's a very dynamic person. We are looking forward a lot to work with sir with a sweet smile and a dynamic face and a very strong vision that he has for Foxy. Sir, welcome you, sir. On behalf of Foxy, I have the great pleasure to welcome you for our journal club of OGSSI and Foxy together, sir.
I think sir is not joined.
Is there there?
I don't think it's joined.
Can we invite
Madam
you?
is
Not
Yeah,
joined.
madam is there. Yeah. Can I have madam's
Next slide, please.
Yeah. And I have the great pleasure, honor, and happiness and gratitude to welcome Madam Dr. Madhuri Patel, who is the Secretary General of Foxy, a woman with lot of energy, lot of dynamicity, at the same time working for every one of us with day and night. Whenever we want her, she's there to help us. Madam, we owe a lot to you and looking forward for your dynamic. You are so sweet to work as a Secretary General for Foxy, the right person with so much of dynamicity and vision, madam. And the madam is the present Secretary General, and she was a honorary clinical associate of Vadia Hospital, Parel, Mumbai, and a honorary consultant to the Police Hospital, Mumbai. Madam,
Dr. Jayarani, yes, will not waste.
So sweet of you, ma'am. Thank you, ma'am. Welcome to our
Yeah,
ma'am.
Dr. Jayarani, thank you very much for your kind and warm words. I remember we just met yesterday, day before
Yes, ma'am.
yesterday, for the Tamil Nadu Federation of Gynecological Society conference in Trichy.
Yes,
And I
ma'am.
met almost everybody of you,
Yes,
and I was so happy. And what I observe in South that all are academicians, whether they are in the private practice or whether they are in the medical colleges, but everybody is academician. And that is, I always feel that yes, something is lacking somewhere. But the South people, they are always there. If they are attending conference, they will attend fully. If they are attending webinar, they will attend fully. Because why I remember it that, after this Trichy Society conference, other conferences, and we are in Salem, Yuva Foxy. And that time, Frank Yuan, who is now President Figo elect, he had, had a workshop for bridge, vagina bridge. And you believe me, up to 8 p.m. the workshop was going on and hall was full. So you all are academician, each and everyone, and I really appreciate that part. So with this, respected Dr. Jaideep Khan, our president, Foxy, soft-spoken, dynamic, then our Macharvila, my dear, not colleague, I will say, my student only, I'll consider her. And I'm very happy to see her to become a vice president, and I want her to rise more. And of course, Surekha is very hardworking, and I want her also to go high and high because these are all hardworking and academicians, and we are in need of that. And of course, Dr. Jayarani, our president of the OGSSI, and Kundika, she's also there. I met them, and they are also very, very capable of coming into Foxy and going higher and higher. And of course, we have expert Dr. S.P. Jaiswal, Dr. Ganita, Dr. Nandita Thakkar, and convener Dr. Priya and Mohan Pramila, and all my dear friends. Very good evening to all of you. I would like to thank all of you for giving me this opportunity. This clinical, research, committee is doing such an excellent work. And you remember that even ICU is also carrying out this work. Even Jogi is also carrying out the work. So it is so important as an academician and as a practitioner to know. Now today's topics are excellent. That how adrenaline, fetal adrenaline is going to tell you whether it is going to be successful induction or not. Similarly, endometrial cancer scoring in asymptomatic patient, is really good topic. And I hope everything will be fine. Recent advances, it is combined with recent advances. And how the junior will know how to select the topic, how to conduct the, study, and what are the, advantages and disadvantages. Because when you have publication in index journal, it is very, very high quality paper. And in a Jogi, we started with except, workshop, which we are giving once, to the AICOG, then 4 in Yuva Foxy, and we are giving to 15 societies this workshop. And you believe me that we have such a good quality paper. This has been going on since last 13 years. And there are good quality of papers we are getting. In journal, I must say that I got, now I'm an editor-in-chief. So we get thousands of paper per year. And we have to only, select the 100 of papers. So our 900 papers are rejected. So don't feel disheartened why we have rejected a paper, because we have no choice but to accept, papers, and other we have to reject. So only 10% we can accept. So, but it is very disheartening that paper which are rejected, they are published in a good journal. So that also happens. So it is very disheartening to the editorial team also. But you must understand that we have to only select 100 papers out of 1,000 papers. If we put more factor, and therefore we would try to restrict our papers, and it is almost all in demand because publication is required everywhere. So you must do, it is required for your promotion, for getting grants, so many things. And that's why you should be well versed with all the clinical risk methodology. With this, I congratulate OGSSI Clinical Research Committee and OGSSI for the excellent webinar which they are conducting since 1 year. And I wish them best luck for their future endeavor. Thank you once again for giving me this opportunity.
Thank you, madam. Thank you so much. Thank you for your presence in midst of even your so much of throat infection and cough and all. It's so nice of you to give your time and encouraging words to us. Thank you, ma'am. Thank you so much. Can I have Charmula's CV? Yeah. So I have the great pleasure and honor to introduce our young and dynamic and ever smiling sweet Charmula Ayo, who is the Vice President of FOXY 24. We know her as a dynamic person working for the Clinical Research Committee for FOXY between 2016 and 18. And she was the ICOG Governing Council member, and she's the national coordinator of so many international faculties like societies like UNICEF, FOXY PCA, MEDA FOXY PG program, Izar Gurukul program. And she was the series convener of the Journal Club of ICOG and ICOG certificate courses between 22-23. And she's the WHO Southeast Asian MDSR member, which is a very great credential. And she's past secretary of the Trichy OG Society and the secretary of the Justosis of the Indian Association. And she's the president of the Menstrual Hygiene Committee Management Consortium and the secretary of the academic wing of ART Trichy. Over to you, Shamla, for your words of wisdom and encouragement and enlightenment.
Thank you, Jairani ma'am. Thank you so much for that kind introduction. We're extremely happy to see Sureka, the Clinical Research Committee chairperson, conducting a program with OGSSI Clinical Research Committee. And it's an honor that Madhuri Patel madam came to the program because she is my teacher and I've learned from her from my postgraduate days, and always a very, very kind person who has helped so many of us and is mentoring us also. And Jairani ma'am, your dynamic work for the past year in OGSSI is well known, and I know you're always academically oriented and you would like to develop academics in a big way, and this endeavor of yours with your society is very praiseworthy. The only thing I had the contention with Priya, she's doing it on the same day as the ICOG is doing. So the too much of clinical research in a single day for people to digest, I think. So one of us have to shift days probably. But the topics that have been chosen today are extremely very important for our clinical practice, because induction of labor as well as endometrial hyperplasia needs some discussion before we manage both of them. And I'm extremely happy to see the secretary, Dr. Kundavai here, and the expert, Dr. Jaiswar ma'am. And it's always a pleasure to meet you, ma'am. And the moderators, Dr. Ganita and Dr. Nandita. Dr. Nandita, I know her for a long time, and she's one person who can clear doubts, even at the smallest level in ART, I know. And we have discussed so many times with Dr. Nandita. The presenters, Dr. Janushri and Dr. Nimra, as well as the moderators, Dr. Ganita and Dr. Nandita, and the conveners, Dr. Priya Kannappan and Dr. Mohana Pramila. I wish both the committees the best of luck as well as good wishes for the entire year. And I know Sureka is doing extremely good work in other parts in her other types of work. Everything she's making clinical research so interesting to listen to. And that's one great achievement, Sureka. And I know it's not easy to work that much in clinical research. They're doing a tremendous job. Best wishes to you as well as the OGSSI Clinical Research Committee.
Thank you. Thank you, Charmila, for your nice words of encouragement. Really looking forward for all of my committee to work forward with you, with your dynamic guidance also. Thank you so much for joining us. And thank you so much. And over to you, Priya. Oh, yeah, I would like to,
Madam Dr.
I would like to have words of
Dr. Jayarani,
yes, ma'am.
can I make one comment?
Yeah.
Charmila said that one of you have to shift on, this. So I would like to say that Wednesday, my third Wednesday of the month, so don't keep on Wednesday, okay?
Yes, Tuesdays, usually our Tuesday, first Tuesday is our EC meeting, second Tuesday Journal Club, third Tuesday our webinar, fourth Tuesday is our clinical meeting. That was a thing that we were doing a lot of over the
So
past.
don't keep on Wednesday. I'll be doing on third Wednesday of the month. Okay.
Sure, ma'am. Sure, ma'am. Sure, ma'am. We'll do it, ma'am.
We're all partitioning ourselves.
Yeah.
So few minutes, few seconds, I think I should take because a lot has been already said. I would just like to acknowledge our Foxy president,
So
Dr.
I would
Jay.
like to tell only one thing. Sureka is the mastermind behind Priya's every work. She has been guiding her, giving her all the support, taking all the best things, and getting the best for the Priya is only because of Sureka. So I would like to thank Sureka. It's
Thank you.
good
Thank you. I think that is very kind of you, Dr. Jairani. But I would really like to acknowledge our Foxy President, Jaideep Tang sir, Dr. Madhuri Patel, our Secretary General, and Dr. Charmila here, who has joined, at a very last, very short notice. I really thank them. And I would like to thank you yourself, Dr. Jairani and Dr. Priya here. Dr. S.P. Jaiswar is our contribution from the Clinical Research Committee, Foxy side. And otherwise, I think Priya, who has worked hard to get the moderators and selection of the topic. And so this is a very good collaboration, Dr. Charmila and Dr. Madhuri, I would like to say. This because we are contributing national experts and we are having the local team as well as was joining. So it's a really good academic team we have formed. So thank you, everybody. And I think we can now start our academic session. I don't know whether Dr. Jaideep is joining, but if he joins, it's fine. Otherwise, we continue our session. Thank you, everybody, all the dignitaries for joining.
Thank you, Sureka. Thank you. Over to you, Priya.
Thank you, ma'am. Thank you. So now we'll go ahead with the academic session. I will hand it over to the Master of Ceremony, our Mohana Pramila. So can you take over and you can introduce the expert for today?
Yeah, thank you, Priya. It's my immense pleasure to welcome all the seniors, the president, secretary, and the vice president of Foxy, and the chairperson of Clinical Research Committee, Dr. Sureka ma'am, for guiding us all the way. And thank you, Priya, for guiding me in this journal club. Because of your guidance only, I'm able to do a lot of work. Thank you, and it's very interesting to work in the journal club. And I welcome our President, Dr. Jairani ma'am, and the Secretary, Dr. Kundavi Shankar. We have two very interesting topics today, and our expert is Dr. Shyam Pyari Jaishwar. Madam is a professor and head in Department of Obstetric Gynecology, KGMU, Lucknow. She had many honors and awards, and she is a member of. She is a visiting professor at BP Koirala Institute of Health and Science, Dhahran, Nepal. Madam has many national and international publications, that is more than 100. And Madam is a member of LOGS president, and she is president from 2022 to 2024. And she is the president of ISOPAB between 2020 to 2022. She's a vice
Thank
president.
you, Dr. Pramila. Thank you so much for nice introduction. Thank you. And thank you for inviting me in this webinar. And this is the scientific journal. I really feel happy to join this journal club. So my thank you and best wishes to all of you. And I feel happy to see so many people, Dr. Sureka, Dr. Jairani, Dr. And my Dr. Charmila, and thank you to Dr. Madhuri and Dr. Secretary General and Dr. Tank also for you have invited all of them on this platform. And really, I'm also feeling very happy to be on the same platform. Thank you so much.
Thank you, ma'am. So let's go to the first topic of the day is the very interesting paper that is about ultrasonic measurement of fetal adrenal gland size for the prediction of success of induction of labor among the primary gravida beyond 40 weeks of gestation. We have the presenter, Dr. Janushri. Janushri Sudish. She's a UG from Sri Ramachandra Medical College. She's a final year postgraduate from ACS Medical College and Hospital. We have the moderator for this paper is Dr. Ganita. Madam is a Professor, Department of Obstetric and Gynecology, ACS Medical College and Hospital. Madam did her undergraduate from Lady Harrington Medical College, New Delhi, and PG from Government Medical College, Mysore. She is a member of OGSSI and published many papers in the national and international journals. Her area of interest is social obstetrics and menopause. Welcome, ma'am. Welcome, Janushree. You can start your session.
Good morning. Good evening, ma'am.
You are audible, eh? Start.
Yeah, you are audible.
One second, I'll just share my screen.
Yes, we can see your screen.
Your screen is visible. Do is full screen. Huh? No, now it's okay. Huh?
Good evening. My topic for today is ultrasonographic measurement of fetal adrenal gland size for the prediction of successful induction of labor among primary gravida beyond 40 weeks of gestation. My moderators are Professor Dr. Ganita ma'am. So my journal has been published by Richa et al. It was a study conducted in Tech Bahadur University in the year September to October 2023. So introduction, prolonged pregnancy is defined as pregnancy at and beyond 41 weeks of gestation is the most common challenging condition currently faced by obstetricians because of increasing morbidity and mortality. Risk of perinatal mortality increases by twofold at 42 weeks, fourfold by 43 weeks, fivefold to sevenfold at 44 weeks. The increased neonatal risks such as meconium aspiration syndrome by 0.24 to 1.42%, neonatal acidosis, 5-minute Apgar score less than 7, and NICU admission. Increased maternal risks such as increase in maternal morbidity incidental due to hazards of induction of labor itself, labor dystocia, which is 9 to 12% versus 2 to 7% at term, severe perineal injuries due to macrosomic baby, operative vaginal delivery, doubling the rate of cesarean delivery, which is 14% versus 7% at term. Hence, to prevent these perinatal morbidities associated with post-term pregnancy, they have induced the patient as per their institution protocol between 40 to 41 weeks of gestation. It is essential to identify the women with higher chances of failure of induction of labor to prevent these morbidities due to induction failure. Hence, there is a need for marker for prediction of successful of induction. Various screening methods have been studied so far for predicting the outcome of induction, such as digital assessment of cervix using Bishop score, radiological assessment of cervical length using transvaginal ultrasound, biochemical factors like fetal fibronectin, interleukin 8, phosphorylated insulin like growth factor binding protein 1. New modality now available is measurement of fetal adrenal zone enlargement has emerged as a prediction of successful of induction of labor. So the adrenal glands are composed of two heterogeneous type of tissue. The outer one is cortex derived from intermediate mesoderm, and the inner one is medulla, which is derived from the neural crest, ectodermal in origin. The adrenal cortex tissue first appears at 33 days of fertilization. It differs from its adult counterpart as it is composed into two distinct zones, which is the inner part known as fetal zone and the outer part, which is the definite zone. The inner fetal zone is enzymatically active and produces large amount of adrenal androgens that are used by placenta for estrogen biosynthesis. On ultrasound, the fetal gland appears as oval or pyramidal in shape in longitudinal dimension, lentiform or discoid shape in transverse dimension. It appears as echogenic central stripe with surrounding hypoechoic rim. It is usually visualized at end of first trimester, but only reliable between after 20 weeks of gestation. The size increases linearly from 12 to 17 weeks of gestation. So this is the fetal adrenal gland on ultrasound now. In between, this is the fetal zone, which is the length, and this is the whole fetal adrenal gland. And this is the width of the fetal zone, and this entire thing is fetal adrenal gland. So the same pictures. And this looks like pyramidal shape or oval or lentiform shape. So why we checking fetal adrenal gland, how we see if it's useful induction of labor is, fetal hypothalamus secretes fetal CRH, which acts on the fetal pituitary, releasing ACTH that acts on the fetal adrenal glands, which main product is DHES, that is the dihydroepiandrosterone sulfate, which releases estrogen. Also produces cortisol. The cortisol acts on the placental CRH and releases estrogen and stimulates production of fetal cortisol, prostaglandins, interleukin 6 and 8. The placental CRH acts on the uterus, releasing PGF2 alpha, which increases the oxytocin receptors in uterus, causing the increase in intracellular calcium channels, which causes contractions. Increasing estrogen receptors on uterus, increasing stretch receptors, and decreases progesterone receptor on uterus. They also act on the fetal membranes, which releases PGE2. So this is the cycle. The fetal pituitary acts on the fetal adrenal gland, releases fetal cortisol and DHEAs, which acts on the placenta. The placenta releases estrogen, which causes uterine contractions. So hence, activation of fetal HPO axis is significant for enlargement of fetal zone, which indicates the fetal readiness for labor and hence being measuring for prediction of successful of induction of labor. So the aim of this study was to use the role of ultrasonographic fetal adrenal gland enlargement for the successful production of induction of labor among primigrávidas beyond 40 weeks of gestation. Primary objective was the ultrasonographic fetal gland enlargement dimension to determine the sensitivity, specificity, positive, negative predictor value in primigravida beyond 40 weeks with successful induction of labor. The secondary objectives were to measure the minimum cutoff for the fetal zone enlargement required for the prediction of successful induction of labor, and to compare this fetal zone ratio, which is also called as FCR, to compare with the transvaginal cervical length and Bishop's curve to see which is more effective. The materials methods were cross-sectional study for primigravida beyond 40 weeks. All the suitable cases were enrolled. Prior to induction, fetal adrenal gland dimension were measured, but Bishop's score were done, and transvaginal cervical length were measured. Sample size was calculated found to be 140. Inclusion criteria were primigravida, single-gender pregnancy in vertex presentation, intact membranes at or beyond 40 weeks who are not in labor, with regular menstrual cycle and are short of dates or dates corresponding with first trimester ultrasound. Exclusion criteria were fetal distress, meconium stain like a cord collapse or abruption, placental abnormalities like abruption, placenta previa, CPD, or scarred uterus like previous history of C-section or myomectomy, hypertensive disorders, diabetes mellitus, asthma, TB, anemia, and epilepsy, macrosomia, FGR, congenital anomalies, and Bishop's score below 6. All the patients were given written informed consent. Fetal biometry, Bishop's score, and transvaginal cervical length were measured. The fetal adrenal gland dimension were measured using abdominal probe, which is 7.5-10 megahertz linear array probe and a 3.5 to 5 megahertz curved array probe. The closest adrenal gland in the transverse plane was identified. Length and width of the total gland, as well as the length and width of the inner fetal zone, was measured using after placing calipers directly over the intersection of the gland and surrounding soft tissue, as well as the intersection of fetal zone and the surrounding gland. The patient was induced with dinoprostrone gel, and labor was monitored as per WHO protocols. So we categorize successful induction as women entering into the active phase of labor, which is 5 centimeter cervical dilatation and more. Failed induction were patients who failed to progress to active stage of labor in spite of 3 doses of dinoprostrone gel, followed by amniotomy and titrated oxytocin infusion. So this is how we measure the fetal zone ratio. The inner is the fetal zone, the hypoechoic area. The surrounding entire length is the fetal adrenal gland. So results. A total of 140 women were enrolled and categorized into two groups. Group 1, which was successful induction, comprised of 103 women. Group 2 was failed induction, comprised of 37 women. The mean
Problem in network? Hello? Hello? Problem in network? You're not able to listen?
network is issues. Yes. So sensitivity and specificity of fetal zone width ratio was better than compared to the 1 minute.
Can you disconnect as well?
Please go back because we are not able to listen clearly.
Yes, ma'am.
Problem in network? You're not able to listen?
Am I audible now, ma'am?
Yeah,
Now
you're
you are
audible.
audible.
You're audible.
Yes, ma'am.
You
So
can
the
proceed.
sensitivity, specificity of fetal zone width ratio was better than the fetal zone length ratio. So by using the ROC,
Tanushri, can you
for
please go back to the previous slides because we were not able to hear it. So can you go back to
Yes,
the
ma'am.
last two slides?
Yes, ma'am.
Yeah.
So the mean of fetal zone length was compared to the mean of total gland length, and the mean of the ratio of both was calculated and found to be statistically significant between the two groups. This shows that successful induction of large fetal zone has better successful induction of labor. Similarly, the mean of fetal zone width and the mean of total gland width were also measured. The ratio was calculated and found to be statistically significant. The sensitivity and specificity of fetal zone width ratio was compared to the fetal zone length ratio, among which the fetal zone width ratio was more better. By using the ROC comparative analysis, we determined that the fetal zone width ratio showed superior to the fetal zone length ratio. So according to which the fetal zone width ratio was calculated, was taken as the fetal zone enlargement, and which is used for the study. For the prediction of successful induction of labor, the cutoff value for Bishop's score was taken to 4 based on the ROC curve, which shows that higher the Bishop's score, more favorable for successful induction and suggests cervical ripeness. Similarly, for prediction of successful induction, the labor cutoff was given for transvaginal cervical length as 2.5 centimeter, showing that shorter transvaginal cervical length has better favorable for successful induction of labor. So the cutoff value among the according to ROC for fetal zone ratio was 0.365. For transvaginal cervical length was 2.5. Bishop's score was 4. On comparing all four, the sensitivity, specificity, positive predictive value, and negative predictive value for fetal zone ratio was showed better prediction of success of labor and was higher. Hence, the combined value was nearly similar to FZR alone. Hence, FZR alone can be used as a ratio as a good marker for prediction of induction of labor. The comparison of intrapartum complication like fetal abruption, MSL, and non-progressive labor was statistically not significant between the two groups. The mode of delivery in group 1, 99 had normal vaginal delivery. 2 underwent section, 2 underwent instrumental delivery. In group 2, 37 had cesarean delivery. Postpartum complication, there was no significant difference among the both groups. Mean birth weight of neonates in the study were 2.9 kg. 55% birth weight were between 2.5 to 3 kg. 60% among which were male babies and 39.3 were female. 30 out of 140 neonates were admitted in NICU. So, prolonged pregnancy is associated with increase of maternal as well as neonatal morbidity and mortality. Hence, to avoid the risks, induction of labor is a common practice in modern obstetrics to reduce the risk. In this study, prior to induction of labor, fetal adrenal gland as well as transvaginal cervical length and Bishop's score assist, fetal zone and length ratio and width ratio were obtained. Very few literature have been reviewed till date suggest fetal role enlargement for prediction of successful of labor. According to a study by Fitzgerald et al., it was a prospective study of singleton pregnancy whose fetal zone enlargement was calculated and compared to transvaginal cervical length and Bishop's score, successful induction of labor and its outcome. Patients were induced by vaginal meso, Foley catheterization, IV oxytocin, or a combination of all. Primary outcome in this study was to see the route of delivery. The sample size was 74. They labeled a cutoff for fetal zone ratio of 0.35. According to their study, they found that fetal zone ratio was significantly higher in successful induction of labor as compared to failed crowd. So they used a cutoff of 0.35. This shows in this study the gestation age. The x-axis shows the gestation age and y-axis shows the fetal zone ratio. So higher the ratio of 0.35 and above shows successful outcome of vaginal delivery and very few fail induction. They concluded that enlargement of fetal zone and adrenal gland indicates fetal readiness for labor and predicts the successful induction of labor and can be used as a reliable tool for selecting candidates for induction. So FCR more than 0.36 is found to be a strong independent predictor of successful induction of labor in this study. According to another study by Avi et al., it was a prospective study conducted in Israel between 2019 and 21. With inclusion criteria of Bishop's score within 6 singleton pregnancy, induction was done by dinoproston gel or Foley catheter, total of 94 patients. It shows no significant association between successful labor among higher maternal age, parity, and lower BMI. Association was noted between fetal adrenal length and estimated fetal weight. They concluded saying fetal adrenal gland biometry was inefficient in predicting successful induction of labor. According to various studies like Mohammed et al. And Belma et al., measurement of fetal adrenal gland volume can also be measured in predicting successful induction of labor. However, there is no study to compare or justify whether fetal zone ratio or fetal adrenal gland volume is better in predicting the success. So the strength of this study was, this was the first Indian study to determine the minimum cutoff value of fetal zone ratio more than 0.36 for prediction of successful of labor. Our study population was a homogeneous study which among only Indian ethnicity. Only a population included primary with singleton pregnancy with 40 weeks and thus controlling many confounding factors. All women were induced by dinoproston gel, so procedure of induction was similar in all. The limitation of this study was they were limited to one hospital setting. Sample size was small. So larger sample size recommended for more reliable interpretation of results. The result of this study cannot be extrapolated in larger population. There is a chance between inter and intra-observer variability. So in conclusion, fetal zone enlargement ratio more than 0.36 is a strong predictor for successful induction of labor compared to transvaginal cervical length and Bishop's score. It can be used for screening the women who are destined for induction failure so that the adverse effects of induction of labor itself can be avoided. If the prediction of success of induction of labor is low, then strict monitoring of labor plotting partogram is important for early decision for LSCS. As the sample size is small, further studies with large sample size are suggested. And these are my references now.
Dr. Ganita madam.
Ganita ma'am.
Yes, ma'am.
Ma'am, you
You
can
mute the
moderate.
discussions, and then we will call the expert to give her opinion, ma'am.
Ma'am, actually, we first thank the OGSSI team for giving us this opportunity. We also thank our HOD, Dr. J.K. Kalaiselvi ma'am, and Professor Dr. Vijayalakshmi Janashekaran ma'am for giving us this opportunity. So, the close association of the fetal adrenal gland in the physiology of initiation of labor, noting this close association has helped us. Probably the fetal zone ratio may be used as a good predictor for the induction of labor. And the advantage of discussing this study is this is the first of its kind in India. And we found that there are not many studies that are available on fetal zone ratio with the induction of labor. The relationship studied between these two is very, very less literature is available on these two. We, of course, when we were going through some articles, we found that the fetal zone, the fetal adrenal volume is being used in the study for prediction of preterm labor and also in the predicting the estimated fetal weight. So there several studies are available, but for fetal zone ratio and induction of labor, only this is the first study in India and only a few studies we could find out. And this being a non-invasive method, if applicable, this should be a very good modality for predicting the success of induction of labor.
Thank you, Ganita madam.
Thank you,
Madam
ma'am.
Jaiswar madam, can you give us your views, ma'am?
Congratulations, Dr. Jainshri. Your presentation was excellent. This study definitely is a new topic. The topic is not new. This thinking about that, how it this measurement of fetal zone ratio or adrenal size of the adrenal glands can help in the induction of labor. Definitely, this study is very good and outcome is also smart, good. Maybe the size of the sample is very less because you have taken a limited. But I feel in the same time, if you want to correlate with the person who goes into labor, spontaneous labor early than the 40 weeks, we can make this, can choose, or you can see, take out as maybe they have bigger this fetal zone ratio. So that is not in your study, definitely, but whatever the study you have done is very good and excellent. And the presentation is, but this is the thought. We can do the measurement in the patient who goes spontaneous labor before 40 weeks, and we can make out the relation with this in which we are going to do the induction. Definitely with this, we can counsel the patient and we can keep preparation accordingly about the successful induction, or may the patient may go into failure. So this is nice study. There is no doubt.
Thank you, ma'am. Thank you, Jaishwar, ma'am. Ma'am, I have a doubt. And this estimated fetal weight is not brought into this study. Do you think it's really important to know the weight of the baby?
They have taken weight. Actually, what happened in this study, their idea is about the induction of labor. So induction of labor is, the induction of labor is having lots of other factors also, but they have only concentrated on the size of fetal zone ratio. But that's why I'm saying in the patient who goes into spontaneous labor before 40 weeks, we can use as a control, or you can make can see the difference between these two. That is my thought. Idea.
Yes, ma'am. Thank you, ma'am. It was really an interesting.
Sarika ma'am is still there, I think. Madam, are you there, madam?
Hello.
Yes, ma'am. I saw her name in the panelist list, but I'm not sure. Maybe madam is held up. Okay, ma'am.
Dr. Nandita. Dr. Nandita is there.
Yes, ma'am.
Nandita, madam, you want to opine on the previous case, madam? Anything you feel you can contribute to the discussion, ma'am? Madam, you're muted, madam. Nandita, madam, we can't hear you.
Ma'am, And Nandita ma'am?
Yeah.
Can you
Told
hear
you.
me now?
Yes, ma'am. Yes,
Yes,
we can
ma'am.
hear
Yes,
you.
ma'am.
Okay. I remember many years ago in Mediscan, this was one proposed program that way they will look at the adrenal gland. But that time the ultrasound, was not that well developed. So we did look at adrenal glands. Even as a student, we had a few cases. But we couldn't come to any conclusion as such. But in post-dated and this, probably we can use this paper and develop a system for our own understanding. Because that time the number of induction, the procedures also were much lesser. Now we have Foley's, we have Propes, we have so many things. That time we had only Saviprime gel or whatever gel you were using. So I think it is a very good way forward, and probably look at inclusion criteria, whether it's only the cervical factor, whether it's only Bishop's score, or whether we have just look at other factors to say, okay, induction might fail in this. Looking at a probability of induction failure and the adrenal gland would give us a new insight or a new arm that can be looked at very closely.
Thank you, ma'am.
So we can go ahead
Any
with the second
questions?
session now.
Okay. It's my the second session. It's a very interesting paper. It's a predicting the risk of endometrial cancer in asymptomatic women, the model development and external validation. It's my pleasure welcoming Dr. Nandita ma'am to moderate this session. Madam is the Medical Director, Nandita Fertility and Research Center. She is an academic head and coordinator, senior consultant, Mehta Hospital, Chennai. Her area of interest is reproductive medicine, high-risk pregnancy, genetics in OB/GYN, lifestyle and gynec disorders. She's a very good teacher because I learned the art of egg pickup and embryo transfer from Madam, and it's a still now I remember her whenever I have a difficulty in any ART procedure or any difficulty in any that is the ovulation induction. Madam will be ready to clear the doubts, and she's a very good teacher, and she's focused her focused training programs are the skill training workshops and designing teaching modules. She's presented many papers in the national and international conferences. Welcome, ma'am.
Thank you, doctor, for these words.
And to present this, I welcome Dr. Nimra Amtul. She's a registrar, Department OB/GYN, Dr. Mehta's Hospital. She did her undergraduate from Sri Ramachandra Medical College, her MS OB/GYN from Savita Medical College. Welcome, Nimra. You can start your session.
Good evening, ma'am. I will start sharing my screen, ma'am.
Yeah, your screen is visible.
Good evening. Today I'll be discussing the journal Predicting the Risk of Endometrial Cancer in Asymptomatic Women, that is the precision model, and its development and external validation. This journal was published in the British Journal of Obstetrics and Gynecology in the November 2023 edition, and it's by Sarah Kitson et al. And I'm presenting under the guidance of Dr. Nandita. So endometrial cancer is the fourth most common cancer in the UK with
Sorry, Nimra, to
almost...
interrupt. The image, can that be
Is it not visible, ma'am?
something? Yes. Yes. Now better, but we can see that. Yeah. Better.
Now,
Thank
ma'am?
you.
Yes,
Yeah.
Yes. Now it's better.
So,
Thanks.
Okay.
Endometrial cancer is the fourth most common cancer in the UK with 7,900 cases diagnosed annually, which has increased by 59% over the past 30 years. And we need prevention strategies to reduce the burden of this disease. And there's a strong association of endometrial cancer and modifiable risk factors. That means there's a possible potential to intervene. With almost 60% of endometrial cases could be preventable. That's the thought. And endometrial cancer has a strong association with obesity, unopposed estrogen, chronic low levels of inflammation, and hyperinsulinemia that drives the endometrial proliferation and accumulation of cancer-forming genetic mutations. So that's why they developed the precision model. The precision is a predicting risk of endometrial cancer in asymptomatic women study, was designed to develop and externally validate a new endometrial cancer screening, a model for asymptomatic women between age 45 and 60, and to give a 10-year risk of developing of endometrial CA. And they developed this formula, and it includes a lot of risk factors like age, BMI, waist circumference, age at menarche, age at last childbirth, the age at menopause, so their late menopause, if they used any hormone replacement therapy, if they used any OCPs, any tamoxifen use, any smoking, and family history of bowel cancer. And they put this formula together, which is currently available for use. And they also have a precision basic model, which they took out a lot of the other variables and only included age and BMI. And based on this, they calculate the 10-year risk of developing endometrial cancer. So the purpose of the study is the development of endometrial cancer risk prediction model and to externally validate it in the UK, primarily for primary care use. And that is the main outcome that they measured is the endometrial cancer diagnosis within the 1 to 10 year of the index date. And it was a cohort study. And it was the model development was by the UK Biobank, and they provided the primary patient population. And that was externally validated with primary care team, which was from the Clinical Practice of Research Data Link, and the secondary care team, which was by HES, and Mortality and Cancer Register dataset was also used. And the population that they used, they had 3 criteria. One was the women have to be between age 45 to 60, and they have to have no history of endometrial cancer, and they should not have undergone a hysterectomy. And the model development was performed using a flexible parametric survival mode and a stepwise backward selection, aiming to minimize the information criterion. And the performance was evaluated on external validation through flexible caliber plots and calculated the expected to observed ratio and C statistics and decision curve analysis. So this is the population they studied. As I said, the development of the model was from the UK Biobank. They had close to 5,02,000 participants. And after the participants that withdrew, they had 5,02,492. And then they applied the inclusion criteria, which they had to be females, age 40 to 70, with no prior history of hysterectomy. And finally, they also excluded the endometrial cancer cases and came to a total of 2,22,000 patients. And for external validation, they used the CPRD and the GOLD and ORM, which the difference between the two populations is how the data was, the different softwares that was used to get the data from the primary care team. And in the GOLD, they took almost 8 lakh patients, and they removed a duplicate, which came to 49 lakh. And then they applied the inclusion criteria, which was the age, and they took out patients who underwent hysterectomy. And finally, they came to a risk of 5,01,264. And then we further removed the patients with endometrial cancer, and they came to 5,12079 patients. And from the CPRD ORM cases, after applying the inclusion-exclusion criteria, they came up to 25,898,292 patients. So it's a very large sample that they used. And when you compare the statistics between the two, that is the development from the biobank and the validation from the CPRD cohort, the age was extremely comparable from both the groups, except that the cases were in a younger population. So in discussion, they thought, was this a bias? But it was not statistically significant difference in age. And a lot of ethnicities were evaluated, whether the ethnicity was white or black or mixed or Indian or Pakistani, and both of them were comparable in both the primary development group and the external validation group. And then coming to the BMI, they quantified the BMI as less than 25, 25 to 30, 30 to 35, 35 to 40, and more than 40. And even the BMI was comparable in both the groups. And when they came to the waist circumference also, it was comparable in both the groups. What was different is that we did not have the age at menarche in the secondary validation group. In the CPRD cohort, they did not collect that data. And when you see age at menopause, and if it got into study premenopausal, and the age was less than 55, was higher in the biobank cohort compared to the CPRD cohort. Parity, when you compare the parity, nulligravidas were more in the CPRD cohort, and this was a difference between the two groups. And the age at last childbirth was also comparable in both the groups. They also studied whether the patients had diabetes, and that was comparable. And the use of oral contraceptive pills more than 5 years is thought to be protective against endometrial CA. So that they quantified as less than 5 years and more than 5 years. And a lot of patients in the CPRD cohort had used or not used for less than 5 years. They also thought about HRT use, and that was also comparable in two groups, as well as the tamoxifen use. And finally, they came to the personal and family history, and they quantified based on smokers, whether they are never smokers, current smokers, or they were ex-smokers, and those were also comparable in two groups. And the family history of colorectal cancer was also comparable in the two groups. Finally, they plotted it to check for the external validation, and they found it to be a well-validated study because it was calibrated on the external validation slope of 1.14, and the confidence interval was 95% of 1.11 to 1.17, and with moderate and good discrimination, at a C statistic of 0.70, of 95% confidence interval of 0.69 to 0.70, and had improved net benefit compared to previous developed models. So we can see like the dotted line is the reference, and our groups are the green dots, and they all lie within the 95% confidence interval. And then let's compare the net benefit. So in the first chart, that's the A chart, the red line is the do nothing, and blue line is EC prevention strategies for all, whereas the green line is applying the precision model. And if you see that the precision model at threshold of 0 and 0.005 has an improved net benefit compared to both doing nothing. And then coming to the chart B, where they compared the basic model as well as the precision model, both of them were very comparable. However, the precision model was superior in the net benefit. So we don't have, there are three models for that are currently in use for prediction of risk of endometrial cancer. So quickly to discuss them. First is the EPIC model. This uses the age at menarche, age at the first and childbirth, and the number of term pregnancies, duration of oral contraceptive use. And for postmenopausal women, it has additional questions like age at menopause, past or current HRT use. However, when they tried to validate the EPIC model, it did not perform well in the UK biodata and the CPRD dataset. So it failed external validation. And then we came to the PLCO-NIH model, which had studies for cohort base of prostate cancer, lung cancer, colorectal cancer, and ovarian cancer, and with US specific population. So when it came to the endometrial model, they studied the parity, the menopausal status, the age at menopause, BMI, smoking, OCP use, medical hormone therapy use, and any interaction between the BMI and the hormone therapy. But we need to further sub-study it for population-specific indices because this was developed in the US and they haven't validated it for the UK population yet. And finally, there was the E2C2 model, that is Epidemiology of Endometrial Cancer Consortium model. And this was used data primarily on postmenopausal white women of an age of 45 to 85. And this was validated with three groups, which is the NHS1, NHS2, and the PLCO cancer training. However, the target population is extremely small, only white women who are postmenopausal. So they felt like population who are not white and who are premenopausal would not get the cancer prevention strategies. So it was a very restrictive population in this model. So to conclude, the precision model has easily measured anthropometry like BMI and waist circumference, and reproductive history is extensive based on the parity and the age of menarche and last childbirth, and then personal history based on the smoking use, OCP use, both are said to be protective, as well as hormone replacement therapy use or tamoxifen use, and family history of colorectal cancer is also taken into consideration. And so it accurately quantifies a woman's 10-year risk of developing endometrial cancer, and it could determine the patients who require endometrial cancer prevention trials in general UK practices. So my final thoughts, it's an extremely large sample size and it is externally validated. And they studied a lot of variables, as I said, age, ethnicity, parity, age at menarche, diabetes, OCP, tamoxifen, smoking. and has good external validation, and it's easy to implement on a large scale because the formula is available and we only have to input our data. However, it requires a long follow-up time of almost 10 years to check the actual benefit of the precision model. And we require like an extensive data to validate it to an Indian population. Thank you.
Ma'am Nandita, madam, your views, ma'am.
Yeah. So thanks, Oxy, for this opportunity that we got to discuss this paper. One of the reasons we chose, I think probably Nimra looked at this paper, was we are looking at a lot of obese population coming up. And just looking at the weight and the BMI or the waist circumference, can we give a prediction at all in our population? Probably if you look at our studies from today onwards, there are very, very few papers. I went through the net, but from India, we do not have any paper which is doing parameters. They have studied 2 or 3 parameters only. And the largest study was only around 452 cases, which was published in 2020. But that also had endometrial hyperplasia as one of the parameters. So looking at totally a normal patient and giving a 10-year prediction, probably we as a society and a Foxy drive can pick up certain parameters and throw it out to all the people who are interested in looking at this. Choose your patients, especially when you have factors like early menarche, late menopause, unopposed estrogen action. So many factors are there. We can choose our own model and create one so that we come up with our own Indian data over time. Because definitely endometrial cancer is on the rise. It was not so thing. Even cancer hospital studies have showed there is definitely a 10 to 12% increase in the last decade. So I think choosing a model for your country, they have given a formula. Let us see if it can work in our own population. This is what we thought of when we actually discussed this paper and put it down together. Expert views are, how we can work on.
Thank you so much. Thank you, Dr. Nandi. An excellent presentation, Dr. Himra.
Thank you, ma'am.
And this is really, now it is need. Although this data is from UK, and it's not, maybe their ethnicity is different and so many things are different from Indian scenario. But as Dr. said, day by day, the incidence of endometrial cancer is increasing. Even we are observing this thing in our day-to-day practice. So, and about the obesity, diabetes, these are also hypertension, these are also increasing in our population. So we can this can be used for our population also, but only thing is that it needs long follow-up, because without follow-up it's maybe difficult, or you go to the retrospective things to see whether it is associated with these things or not. So definitely your study is very good, and it is stimulating the thoughts also for the further study in our population. We can do it and we can develop our own data about that. So thank you so much. This is my opinion, because it has taken from the other population, other countries' population, but definitely we can also do it.
Thank you, ma'am. Thank you. When Nimra presented, even I thought why it's UK data. And as Nandita ma'am correctly said, it's very common in endometrial cancer. Every consultant is seeing endometrial hyperplasia in her practice. So we don't have a proper reporting format. So we have to create a common registry, and we have to come out with our data. So our clinical materials is very huge when compared to UK. Only thing we are not reporting it. That is we are lacking. So we can have a very good study on the Indian population also.
We can do it. That's why I'm saying the studies stimulate us also to get this type of study in our own country.
Yes, ma'am.
Good presentation.
Thank you, ma'am.
Thank you, ma'am.
Welcome.
So if there are
Thank
any
you, ma'am.
questions, they can just put it in the chat box or in the
Chat,
question
I'll
and
see.
answers. So I don't think we have any
Yeah, there is
questions
no
as of now.
question. There is no question in the chat box.
Okay, fine. So if
Question and answer also
no
there is
further
no.
questions, I think
Yeah,
we can
no
go
question.
ahead and end the session, I think.
Yeah, it's very interesting session, ma'am. Both the
Maybe
papers are
this
very.
study is unique. The people are still in the dilemma what to do. It's a nice study, no doubt. Can close it.
The one take-home point which everybody likes to give in every meeting, everybody says is we have such a vast case scenarios, but we don't sit and document or we present papers. So whichever, like, in any journal club, when we bring it upon, it is about like, some other abroad countries paper, and we don't have our own local papers
Data,
because we
yeah.
don't randomize. Anyway, like even if we do present, we do it as a case series or case presentation, but we don't do it as a proper randomization and other things. So I think it's high time we start having our own data. So maybe in the near future, and one of our students who are all seeing, so I think they'll be there. And I think some of the few things are there. So, okay, so, okay, fine. So they are like, there are a lot of congratulation messages coming. So both the presentation is good, and particularly the PCO, lean and obese, looking at a difference might also help. So any views on that, madam? Do you think any PCO, whether the lean PCO has a lower risk of endometrial CA? Anything which you have observed over your practice?
Yeah, I've been seeing patients for the last 2.5 decades. The lean PCO turning into diabetic, yes, because their requirements of insulin comes much earlier. They are more resistant than the obese PCO, because obese PCO you can at least talk of lifestyle. Here, it's not the lifestyle; it is their genetic makeup. So probably these come early. We are seeing younger patients with endometrial cancer, though we are taking 45. Few days ago, it was a 43 with an abnormal, pattern. So this patient is definitely at higher risk, and she was a PCO. I've seen her through. She's delivered with me. So it is a challenge. I think we just probably, as a community of doctors doing OG practice, if some take either Oxy takes up or at Foxy, we just feed in data from on defined forms, and they can be analyzed. That itself will throw a lot of light on the pattern all over the country.
It
Yes,
is
ma'am.
true.
And I agree with you. Like, though we say that the lean PCO, they are thin, but even for them, they have a lot of visceral fat. So the same diet plan which we give for the obese PCO is the same thing to be followed by the lean women, but it's very, very difficult to convince them to go on a healthy diet, because they say like already I'm thin and you want me to further reduce my carbs. So the acceptance is little less. Okay, so I completely agree with Dr. Padmaja, who says you have to write a long-term plan for any of these women when you pick up the risk factors early on. Yes, I do agree with that. So if there are no further questions, no further thing, I think we will end the session for today. So thank you, each and every one. Thank you, every delegate, for joining here. I hope this was a very useful session for every postgraduate and also for the practitioners. I thank the Dr. Expert Madam, Dr. Jaishwar Madam, very good thoughts. And both our moderators, Dr. Ganita and Dr. Nandita Thakur, thank you. And both the presenters, Dr. Janushri and Dr. Nimra, you both did a very good job. So congratulations, pulling up. Everybody says good session. Yes, thank you. Thanks a lot.